All right, folks, let's go ahead and get started. I want to welcome you all. Good afternoon. Hopefully everybody's had an opportunity to step away and get some water and refresh for this session. Thank you for joining us. The session is entitled COVID-19's Impact on the Early Childhood Workforce in South Carolina and the Equity Challenges Track. Before I introduce you to our presenter, please bear with me. I've got a few logistical notes to share. You've all heard them a couple times today, but I'm just going to reiterate. This session is being recorded and the chat is being archived. Attendees are in view-only mode to keep things orderly, so you cannot use your microphone. We encourage you to use the chat box instead to engage with the group. You can post here for any technical issues you might experience, as well as any questions you would like to share with presenters. We will share these questions towards the end of the hour. This session uses auto captioning. While these captions will not be exact, we hope they can improve accessibility for all attendees. To activate these as a viewer, please look for an option on your toolbar that says live transcript and select either subtitles or full transcript, which will appear in a sidebar. Your options may differ on a mobile device. If you are attending to claim professional development credit through SE Endeavors for Early Educators, please complete the submission form, which we will share in the chat box shortly. This link will also be provided once more at the end of the session. This is essential to having the information needed to process your credits, and remember that you must attend the session for its full hour duration to receive credit. All right, with all of that being said, at this time I am pleased to introduce our presenter for this session, Megan Carolan, Director of Policy and Research with the Institute for Child Success. Megan?
Great, thank you so much, Amber, and thank you, Christina, my tech guru, for our hour together. We can go ahead to the next slide. Welcome, everybody. Thank you for choosing to spend your lunch break with us today. We appreciate that. The goal of today's session, and here are the learning objectives to sort of formalize it, but essentially here at the Institute for Child Success, we have spent a lot of time over the last year since the beginnings of the public health crisis trying to understand the situation of child care providers and pediatric healthcare professionals, specifically in South Carolina. That's where we're based, and so that's where we sort of have the largest footprint to then turn research into action, but to also align with the broader field. I don't think it's overselling it to say that essentially last March, all of our lives changed overnight. And in settings where folks work with children, those changes have been very nonlinear. And so what we've been doing is a variety of research over the last year that's going to help give us a little bit of a picture of the ups and downs throughout this last year, talk a little bit about some of the lasting impacts on the field. I had thought about just doing this session focused on child care providers, but especially knowing the folks who attend this conference, really wanted to talk about pediatricians as well. These are not necessarily two groups that we talk about in the same sentences all the time, right? Even if you're here today, your professional development credits are through two different systems. Your training is through two different systems. But at the end of the day, these are extremely important professionals working with families on some of their best days and some of their worst days. They're working with the same families, and they're feeling a lot of the same stressors right now, which is not something that we necessarily expected when we started these research studies. And so I think we can learn a lot from what the field in general is experiencing, and that's going to help us focus on sort of a strengths-based recovery for these sectors. Next slide. Let me just say now that the links for these studies are going to be available at the end. And then I'm happy to answer any questions, especially by email, if you read through them and dig in deeper. We have conducted three studies, three surveys in the last year. The first was of child care providers in the spring of last year. We published that in June. And so tried to capture some of the real immediate takeaways of what the crisis was so far. Anybody who does research knows that the trade-offs, of course, are to do rapid response research. Sometimes you don't get as in-depth as you'd like to. You can't really fully know the questions to ask when you're trying to respond so quickly. So in the fall, we did a follow-up survey. Some questions were largely the same, but others were what we had heard in the field that had changed since the original spring survey. So those surveys are not one-to-one comparable. The respondents are different. As you can see with the fall survey, fewer respondents in general. This really spooked us at first. We had done even personal outreach to child care centers. The state doesn't release a list of email addresses for child care centers, but they release their names. So we're on Facebook sending messages to them with this survey, and not getting responses. And that's because as time has gone on, the job of childcare providers has gotten even harder. They are stretched thinner. Administrators don't have time to do an additional survey if they don't really see how it's necessarily going to benefit their work. It just becomes more difficult to get the responses that are needed. The pediatric survey we did over the summer, that was through a partnership with the South Carolina chapter of the American Academy of Pediatrics, which gave us some more direct outreach to providers specifically. So what I want to say is that these numbers are small in the grand scheme of things. We're not going to be running tests of statistical significance on this. The goal here, more than the exact percentages, is looking at the major trends. I'll also note that despite the fact that the numbers are relatively small, the findings are very much in line with what much larger studies have found. The National Association for the Education of Young Children, NAEYC, has also been fielding frequent surveys, and their responses are in the thousands, and they're also seeing very similar trends mathematically. So we have a lot of faith in these figures, even though they were small, though we recognize that in this crisis, things are ever changing, and so we have to continue to update. Just wanted to give a quick look at the demographics too here. Largely, we're hearing from child care centers more than family or group care homes. We also did have some responses from 4K and Head Start centers, which just operate very, very differently because of their funding sources and some of the administrative oversight there. And then with the pediatricians, you can see that there's a little bit more of a mix in there in terms of the different types of practices. I think we define small as 5 providers or fewer. For small independent, not just solo practitioners. Geographic differences too. We tried really hard to capture all counties, and as you can see here, that just didn't work. But we do have a pretty good mix of what we would consider rural counties and urban counties, so some pretty robust takeaways here. Next slide. And next slide. Great. So let's start with the child care sector and what are we even looking at in terms of operations? So as many of you are aware, South Carolina did not issue a blanket closure order for child care centers during the public health crisis. Instead, centers were sort of given some guidance about how to make those decisions. Many chose to close, either for a stated period of time, something like we're going to close for the next 2 weeks, try to do our part to stem public exposures, or they sort of closed indefinitely and said, we'll keep an eye on things. For some, it was closure because of their own safety concerns. They felt that they couldn't adequately ramp up on precautions or supplies. For some, it was staffing. For some, frankly, they also had illness within their immediate family or exposures in their classrooms, and so had to close as a pretty specific precaution there. So in the spring, what we found was that 48% of our respondents were closed for all of their enrollees, and 39% were open for everybody. And then there were a handful in between there who stayed open maybe just for, frontline workers or a more specific category. This was a really startling finding to begin with because the difference between 48 and 39 is not so large here. We can't say that there was one concrete trend in how child care centers responded to the crisis. So without the state issuing a stop order, providers really had to sort of start navigating this from day one on their own. I'm not necessarily saying that that's a bad thing, that the state didn't issue it, but I'm saying that providers throughout this crisis have really had to learn and relearn and navigate a really rapidly changing landscape, generally on their own or sort of in partnership with more local groups. By the fall, all of our respondents were operational. That being said, we know not all centers are operational right now. It just means that those are the ones who are checking their email to see a survey. Most had closed for a period of time and are now open, as you can see. As you can see, only 37% has stayed open the entirety of the time. So a little bit more than 1/3 never closed during the crisis and would not, presumably anticipate closing in the coming future. We tried to take a look at how many centers are closed now permanently. DSS has a pretty robust public database of centers that have reported temporary closures. We don't have any way yet of knowing which of those temporary closures are becoming permanent. That will only really come to light when license renewals need to be submitted. The national figures are pretty jarring that, we could be looking at 1/3 of child care centers closing permanently for some of the financial reasons that we'll discuss today. But it's a little early in South Carolina to be able to give an estimate on that. Next slide. So even for those who did stay open, it is anything but business as usual. And so one thing that we wanted to capture in the fall survey, as we learned more and more, was how respondents were changing their practice to adjust to safety precautions. When we fielded the spring survey, it was actually only about maybe 2 weeks after the CDC had switched their guidance to recommend wearing masks. At that point, there was sort of this back and forth, masks, no masks. We were really focused in the spring of last year on surface transmission. So we heard a lot from teachers about, bleach and Lysol and hand wipes. Whereas by the time we were talking about this in the fall, there was much more public guidance from some of the sources you see listed up there about screening for symptoms, reducing respiratory transmission. So at this point by the fall, there are a lot of resources out there, the CDC, DSS, DHEC, NACI, all suggesting how child care centers can respond. There's no perfect mix of how a center should be responding. It's not going to be practical for most places to incorporate all of these changes. I think it's notable that on average, the respondents to our survey said they were using 5 of these accommodations on this list. Again, there's no perfect number, but I want to convey the sense of turbulence that providers have had to work throughout this crisis. Implementing any 1 or 2 of these changes for your full center could be a heavy lift. Implementing 5 just at the time of the survey is an extremely heavy lift. It requires staff time, it requires planning time, and it requires financial support for implementation for the most part. So this is the reality providers have been living in. You can see the top 3 responses: taking temperatures at the start of the day, creating a policy on how to handle COVID cases for staff and children, and requiring face masks for staff were by and large reported by most of our respondents. After that, there's a pretty significant drop-off. The next most commonly reported accommodation was face mask, reducing the number of children to allow for more distancing. This is important to note that there's only really 3 practices that the vast majority of centers are doing, and then for the most part, other places are sort of tweaking as they go, picking and choosing which parts of this they're going to incorporate. A lot of this has to do with the practical realities of these challenges. To allow for additional distancing for children would mean having fewer children in a classroom. Most centers cannot magically create another room. And so in order to reduce the sizes in one class so kids can be more spaced out, it means enrolling fewer children in general, which can have negative impacts for the parents. Providers were very attuned to, I want to stay open for my families. From a lot of rural providers, we heard, I'm the only licensed childcare provider in a 15-mile radius. I can't close. And so for folks really facing these challenges about how to still serve the families that mean so much to them and make their bottom line and keep their staff safe, it's been a tremendously difficult balancing act. Next slide. We cannot overlook the financial side of things, and we're going to talk quite a bit about this for the providers. I don't think it is a surprise to anybody on this call that childcare is a tough business. The margins are extremely tight. We have long discussed the impacts of low salaries on staff members. It contributes to high stress, high poverty rates among childcare providers, and high turnover. Most childcare centers, especially smaller ones that aren't affiliated with sort of a larger chain or body, are unable to provide the types of benefits like PTO or health insurance that some other businesses are able to. Some of these are challenges for all small businesses in general, but in particular with childcare, we heard this real tension from respondents in terms of, I'm here every day. I am face-to-face with these kids. These kids are sitting on my lap, and I'm considered essential for that, but where's our essential status when it's time for a bonus pay or additional protections? And so this is really sort of where the rubber has met the road to some degree with those financial challenges we've seen in the field for so long. So immediately into the crisis, this is the spring survey now we're reporting on, we asked providers, what are your biggest cost concerns? Because at the time, remember, so many of these providers, almost half, had closed. But there are so many fixed costs with childcare. The bulk of their costs are fixed. You're still paying for that facility, whether it's rent or mortgage. If you want your teachers to come back when you reopen, you're trying to continue paying them, although many providers said that they did, in fact, have to lay off staff temporarily. Many providers reported, draining their savings or we had one provider who said that they'd been fundraising for a new roof and they had to drain all of that funding to keep paying their teachers because they didn't want their teachers to go without pay just because they were closed. So some really difficult financial decisions here. We find it very interesting that facilities costs other than rent and mortgage were so high up on this reported list that over 60% of our respondents said that was a prime concern for them. This is a pretty broad category, including HVAC, utility costs, and insurance. We've also heard since then, in the fall follow-up, folks are concerned about taxes. Everyone's concerned about taxes, let's be honest, but property taxes in particular, as this crisis has gone on, folks are, more and more concerned about those bills that don't have a lot of flexibility. At the time, we were also hearing that almost 40% were concerned about the emergency supplies. This is partly the cost and partly access to being able to get that equipment, and that's a challenge that has continued actually into where we are now. Let's go to the next slide, and we'll talk a little bit about the complex picture of staffing. So in the spring, the biggest concern that we had about staffing was my staff are concerned, my staff don't want to get sick, and the juggling act of unemployment. Providers didn't want to lay off their staff, but for some, eventually it became a financial reality. At the time, you'll also remember that there were those emergency unemployment additional payments being made, that $600 a week. They were concerned that providers, their staff wouldn't want to come back when they recalled them from temporary unemployment. So it was really focused on providers in the classroom. We started hearing some really interesting chattering over the summer about it being a much more complex picture. Now, remember, I feel like we all have to sort of reminisce. We've had so many phases of this crisis. But think back to the summer in South Carolina and everywhere. The conversation was about school reopening and school reopening. And while most of the child care centers we're talking about operate independently from the schools and could do their own thing, their staff were very concerned about school reopening for their own children. And so staff may have been home and with their children more for the virtual school period in the spring, and then they had summer, maybe they were on unemployment, maybe they weren't receiving payment, but they were out of work. Now suddenly we're getting to August and people didn't know what was going to happen with their own children. And so staffing became a really complex issue in addition to the exposures that started happening as children started re-entering the world, and South Carolina had its numbers really spike during the summer. Staff were calling out more often as a result of either exposure or potential exposure that required quarantining. Child care providers said it's been very difficult to get substitute teachers because substitutes who they may have previously called on to come in and work with their infants and toddlers could make a lot more money getting called in by the school districts, who also have a greater need for substitutes right now, while they're also dealing with, higher than usual absenteeism. We talk a lot about unemployment, and yet providers told us they had a very hard time finding and hiring new staff. They were telling us it's taking 3 times longer than usual, whether that was just more back and forth over paperwork or people aren't staying on top of the materials that have to be submitted. They weren't finding qualified workers, which some expressed was a concern about health and safety, folks who would be a great fit, who maybe you have their resume on file from a year ago. They say it's just not worth the risk to my own family right now to come in and have this sort of frontline job. And so the staffing issue became very multifaceted by the fall, and it's not something that I think we would say providers feel they have a handle on at this point. A lot of these challenges are continuing. The availability of the 2 vaccines right now does bring this into sort of a new phase, and we're sort of waiting for the dust to settle on that to see. Are child care providers able to access the vaccines meaningfully? Are they receiving equity with teachers? These are very frontline jobs, and so we'll see if as vaccination becomes more widespread and then, hopefully case rates are going down, if some of these staffing issues are resolving themselves, or if we really are looking at a longer-term sea change in the field. There is some hope that maybe this crisis does bring into light the essential nature of childcare work, and that perhaps can get some more federal support. There has been more federal investment in childcare in some of the recovery bills, but not nearly enough to cover the long-term underinvestment in the sector. So we don't know yet what the future holds for staffing. In particular, we know that families are starting to come back. Next slide, please. In our spring survey, when we crunched the numbers, we asked folks, what's your legal capacity and what's your daily attendance like each day? Now, we wanted to ask about attendance and not enrollment, because many families were asked to keep their child enrolled to save their spot, which oftentimes meant continuing to pay, at least to some degree, to keep the spot. So even during those closures in the spring, we really wanted to know how many children are actually coming in to take those seats each day. And we asked the same question in the fall. Overall, in the spring, we heard that about 1/3 of capacity was actually being used, which is jarring. I mean, that means that 2/3 of the seats in childcare in the state were going unfilled every single day. Some of those families were paying to hold those spots, but many were not, and many providers, frankly, didn't have the heart to charge them. You know, in our qualitative feedback, we heard that a lot. You know, I've been asking families to at least pay $25 a week to hold their spot, and then eventually, they just felt that they couldn't ask people to continue paying that when their own financial futures were so uncertain. You know, they heard from many families that, well, we just had layoffs, and so we don't really need childcare right now the same way that we did, or it's just not an expense that we can handle because of other financial cuts. And so childcare is an industry that is so interwoven with the broader economy. What's happening in the daily, classrooms is really a reflection of what's happening in the local economy as well. So by fall, we're happy to say that we did see some of these slots rebounding. We tried to sort of parse it out a little bit here by ages, and there's not really a very clear trend. You can see that to some degree the infants and toddlers were more likely to keep going in the spring, but not by a huge margin. This might reflect some of the very early media coverage of the virus, which sort of conveyed that children are at much less of a risk. If you've ever been around a preschooler, like my 4-year-old, they just touch a lot of things. It might have felt more feasible to providers to continue serving infants, and families potentially felt more comfortable serving infants because they're not everywhere. They are not breathing on each other's faces. You could sort of, create more of that separation. But when we think about toddler, preschool, and then school age, that face-to-face interplay of the children, the parallel play, the collaborative play, is such an integral part of childcare. We think that a lot of families just felt we can't get that experience right now, and so we're going to, keep the child home for now. By the fall, we were looking at about 2/3 of seats actually being filled on a daily basis. So again, that's rebounding, but it's still 1/3 of those seats going unoccupied, which likely means close to 1/3 of those seats going unpaid for. Childcare is not a business with margins that can absorb a 1/3 revenue loss, and this is a crisis that's been happening for some time now. Next slide, please. So we've attempted to quantify the financial impacts in a couple ways, and sort of subscribing to a do no harm mentality. We're not asking people to take out their accounting ledgers. We asked for a rough estimate about their losses. In the initial spring survey, the losses that were reported, and some of this was not so much losses as increased costs as well, costs from suddenly buying an air filter or hiring a professional cleaner or having to have face masks for everybody. But that financial impact on their bottom line at first, $31,000 per month in the initial months of this crisis, about the first 2 or 3 months. Is a huge, huge amount of money, $31,000 for these providers. By fall, we did see some of that revenue shortfall catching up with the increased enrollment, bringing more revenue back in. Also, as the crisis has gone on, supplies have become more reasonably priced again. We heard a lot in our qualitative feedback about, I can't find face masks, and even if I could, I can't afford them because the prices are being so marked up with the scarcity. So as some of those supply chain issues have lessened and children have come back to the classroom, the financials are improving, but a loss of $13,000 per month every month is really taking a toll. So cumulatively, we'd be talking about $103,000 lost per provider since last year. It's hard to really oversell how significantly that can impact the bottom line of some of these centers and why we expect some of these centers to just not be able to reopen. We also asked providers in the spring, how long could I'm saying centers a lot, I do mean provider. This probably speaks to some of the implicit bias in the field that we pay more attention to childcare centers and not smaller home-based providers. I apologize for that. So we asked, how long could your operation operate if you had to close? This was a very scary question. 1/3 of our respondents could not handle any closure. They said, if we close and stop taking revenue, that's it. We don't have any rainy day fund. Another third did not know how long their facility could handle a closure. And from a small business perspective, this is concerning. We would want providers to be able to have a better sense of what their budgets allow for. But this crisis in some ways really hit folks overnight. They may have been saving for one thing and now those savings are gone, or their center might not have been in a financial place to be able to save at all. A lot of folks are trying to keep their tuition exactly as low as they can so that families keep affording it. And so we've seen a lot of financial trade-offs with that. Other national studies, including NACES, have found that childcare providers are increasingly paying for more things on their own. They are putting expenses on their own credit cards. They are paying with their own savings account for the supplies that the schools need, and so trying to reduce some of the burden of that cost for the families, but taking on more of it themselves, which long-term could be a very difficult financial position. In the spring, only 9% felt certain that they could operate off their reserves for several months. That was in May. Only 9% were even sure they could make it to now if they had closures. I really just want to drive home the severity and the tenuousness of that situation for so many providers. In the fall, we then asked them to estimate how long their reserves could keep them afloat. So not just do you have reserves, but try to really specifically put into days or weeks how long they could keep you going. Again, only 1/3 of respondents were even able to provide an estimate. This speaks to some much bigger issues in the field. You get into childcare because you love childcare, but that does not necessarily mean that your local childcare director also has expertise in accounting and advertising and, culinary preparation. Providers tend to wear a lot of different hats, and they might not have the financial literacy for operating a small business of this size. We think that there's a lot that could be done from community-based organizations actually to build that capacity so that there's more confidence in the future should an emergency strike. But putting a pin in that for now, what we found was that the average operating reserve could hold a provider over for about 2.5 months. So a little bit of breathing room, but given the unpredictable path of this virus and the societal impacts, not a lot of comfort for those worrying about making payroll each month. So at this point, I'm going to transition us over to talk a little bit about pediatric healthcare. Next slide, Christina. Actually, we'll go 2 slides. This was a survey that we did over the summer. We'll talk a little bit about the pediatric findings, and then we'll come back around to the trends and sort of what happens next. So we surveyed pediatricians through the South Carolina chapter of the AAP, and so they were able to directly reach out to folks. Tried very hard to keep the survey brief. To our understanding, at the time we fielded this survey, there was only one other state that was also doing this. So with childcare, we were sort of, in a line with other states that were looking at this. The pediatric providers hadn't yet really risen to this crisis level. Right away, folks started noticing these downward trends in pediatric visits and vaccinations, which we'll talk about a lot, but didn't really have a sense of how that was impacting pediatricians. So this was sort of a new territory for us to explore. What we largely heard in the summer was that practices were remaining open, but made a lot of adjustments. And so 68% were fully open. You could come in for, whatever you needed, whereas 32% were only making in-person available for certain visits. So this often meant a phone call to sort of triage first, or the increasing use of telehealth, which has been a major sea change in the field as a result of this crisis. Broadly, when we asked folks what adjustments they were making, we heard these 4 categories: scheduling, physical space, personnel adjustments, and telehealth. Now, again, this was done last summer, but thinking about my own experiences with my child, you still see a lot of these trends are in effect now. So these have become, following some guidance from the AAP and the CDC, these have really become the structures that pediatricians have been using, and other providers as well, to manage risk. So with scheduling, many pediatric providers anyway do well visit time and sick visit time. So for example, they'll do well visits for babies in the morning and then sick visits in the afternoon, just to sort of keep from mingling patients, especially if you have a smaller waiting room in a city or something like that. So we saw an increase of folks who were reporting doing that for the first time, trying to stagger their days to separate and hopefully reduce risk in case a symptomatic patient was symptomatic with COVID. We also heard a lot of providers were actually shortening their schedules to help reduce some of the staffing costs. They had lower demand, so they'd shorten the days or furlough and try to save some of the administrative costs as the result there. With the physical space, I'm laughing and it's not funny, but it's a little funny. We heard a lot of really novel ways of utilizing physical space to separate sick and well patients. People are being asked to wait in their cars in the parking lot, which is still, a thing. For some places where you have a lot of patients who are, walking in or coming by bus, it was waiting in the hallway. One practice said that they sort of had like 2 separate hallways for waiting and sort of nobody was in the waiting room. Some practices said that they're just never going back to waiting rooms. We have 3 exam rooms. So we'll have 1 patient in each one, and if we don't have space, you'll wait in your car until we do. A couple places, again, this is a summer survey, we're conducting, the majority of their well visits outside or in the parking lot, or they would come to your car to give a shot. So we can say for sure with pediatricians, no lack of creativity in trying to handle these challenges. Personnel adjustments to minimize staff exposure. For some, this was things like barriers and, masking took on much more quickly for pediatricians than it did for child care providers, because for some practices and some procedures, you've been using masks and gloves anyway. They would sometimes do with the doctors in particular, they might do like a weekly alternating schedule for who's on for sick visits versus who's on for well visits. That way folks could sort of have a break with seeing it wasn't always the same doctor seeing all of the sick patients, but at the same time, there was a risk that if all doctors in the practice were seeing sick patients, what if they all contracted the virus and had to close down? So trying to juggle some of that risk sharing equitably. And then telehealth. From the outside, telehealth might seem like a no-brainer, right? Of course, if I just need to talk to you about my child's rash, let's do a video session and we'll take a look and then you decide if we have to go in. But on the back end, the question of why haven't providers been using telehealth before is much more complicated. A lot of it has to do with insurance reimbursement, that insurance plans have generally not been in a hurry to reimburse telehealth, that the HIPAA-compliant technology needed for telehealth is very expensive and requires a lot of onboarding for practices to really get comfortable with it first. And particularly in rural areas, we heard the concern from physicians even now, as telehealth has been more embraced as an emergency measure, ensuring equity between phone and internet. If you have patients whose children, have been struggling even to get the internet access for their hybrid school days, it's going to be an issue to have that telehealth access. You cannot ask a family whose child might be sick to drive to the local, McDonald's parking lot where there's a hotspot and do a smartphone appointment for telehealth. That's not in the best interest of patient health either. And so the challenges are still significant with telehealth, but this has really been a very novel test case of how quickly it could be scaled up for providers and how patients feel about it. Next slide. The trend that we most wanted to circle in on with our focus, I guess I put animation in there. Christina, you want to? It should give us there we go, perfect. Forgot I did that. One of the trends, our organization is focused on child well-being, and so the well-being of those providers and the health of their business is important, but at a very immediate level, we were concerned about our kids still coming in when they should be. And so we explored a couple different ways to try to capture this, and I really want to use caution with this analysis That's a little disclaimer at the bottom. But what we asked was for providers to sort of gauge for us, have you seen a decrease in visits for these reasons? And we asked them to sort of try to capture for us, roughly what percentage would you say? We didn't want anyone to have to download all their stats from their EHR. We were trying to do rapid response, and so we couldn't get into, Medicaid billing files. There's a lot of different ways to do this analysis, and we've seen that from some other folks. But again, our figures are in line with what those other methods are finding as well. The biggest, the most commonly reported decreases were in acute conditions and chronic conditions. So acute conditions, we're talking about things like a minor injury, a rash, a stomach bug. 91% of doctors said that they weren't seeing as many visits for that anymore. For chronic conditions, managing asthma or childhood diabetes, that becomes really particularly concerning because if the family is also struggling with maintenance of those conditions in other ways, the provider might not know about it. And so there was a real concern that when people started coming back to their providers, the child's health could have actually taken a negative turn. And then we heard similar numbers reported for well child visits and vaccinations. So 83% said they had seen a decrease in this. It's concerning, though not quite as severe as the acute and the chronic. We asked on the vaccination question, dig a little bit deeper. Again, this is perception. But the pediatricians, largely reported that it was teens and tweens who were missing those vaccination visits. For the most part, and several federal data sets confirm this as well, babies were still coming in at the same rate, which is encouraging that parents were still comfortable bringing in those under twos for those shots. We're not missing a lot of vaccines in that series at the beginning, which also means they were coming in for well visits, developmental surveillance, and just really the well-being visits there. With teens and tweens, we suspect this was a couple things. One, as the literature started showing us that actually teens and some tweens, they contract the virus more so than do small children. Their bodies sort of respond to it more like adults. And so we felt that there was some evidence that families were more concerned about their tweens and teens exposure level. And sort of a feeling perhaps by parents during the summer that, well, my child isn't in school right now anyway, so how much do I need to worry about this? Let's wait another couple of months and then we'll, try to catch up. Next slide. There was a big concern about this catch-up issue. So you can see here, we crunched some DHEC data on vaccination rates, but I'll note that DHEC has recently revised their data system, and it's going to be a good thing. It's going to make data pulling easier, but as a result, it's very difficult for us to sort of align the early pandemic trends in vaccination with what we're seeing now. The data systems just don't quite align. So we'll tell the story in two different phases. The first is that looking at spring data from last year, using both conservative and less conservative estimates, the vaccination rates were somewhere between 32 and 47% of the pre-pandemic weekly figures. And so going from February to March into April of last year, something like half as many to two-thirds as many, or two-thirds fewer vaccines were being given each week. What this really created was a concern about catch-up when providers did start seeing families coming back in. When schools reopened, where there are going to be so many people coming to flood in that, doctors no longer had in-date vaccines or appointments to see them all. So there was sort of this, I'm not going to say panic, but a pretty significant concern about what was going to happen with that. Outside of South Carolina and sort of more scientific methods, the CDC did a multi-state study, and found a drop-off of 75% between March 30th into, in the week of March 30th. So the pandemic was officially declared that middle of March, like March 13th. And within 2 weeks, nationally, they saw a 75% drop-off in vaccines. So that did start recovering slowly, sort of with each week after that. But we actually still can't say for sure that those numbers have fully caught up. Next slide. We're optimistic in South Carolina that a lot of that vaccination has regained ground. You can see here that as we get closer to when it became clear that schools were going to reopen in some capacity, and thus vaccines would be required to re-enroll and reopen schools, those rates are going up, up, up. That really sharp drop on 9/6 is Labor Day. Taking out an entire Monday of doctor's offices being open really drives down your vaccination rates. But by and large, this was an upward trend, and we think that by the time schools reopened, we really are looking at students with in-date vaccinations. In particular, the numbers of kids 11 and older receiving their vaccines went up significantly during this time each week. In fact, nearly doubled by the middle of August compared to the beginning of June. So we do think that there's been recovery in that area, though we would say no one should let their guard down. What we're not going to talk about today, because it's a whole other session, is vaccination issues related to COVID specifically. The vaccines, and these are the vaccines on the market right now, are approved for children under 16 anyway, so the vast majority of pediatric patients wouldn't be eligible regardless. We know that it's something that pediatricians are talking about and preparing for, and how do you talk with parents about it, but it's just sort of too early to really have that conversation meaningfully in this conversation today. Next slide. So we also asked the providers, what are the issues that you're experiencing sort of from a business side? A lot of us don't like to think about our doctors as a business, but they are. If they can't make the money to stay open, we're not going to have the doctors that we need to take care of our health. We tend to focus on that community service role, but at the end of the day, the dollars have to make enough sense to keep operating. We did hear issues with accessing PPE, especially masks. This is also among folks who already have medical supply contacts, who already are getting supplies in, like exam paper, masks, gloves, hand sanitizer, but suddenly they were competing against everyone else. I mean, local businesses, stores are buying gloves for their customers to provide, and masks, and so suddenly they were in this bidding war with other places and had to make some decisions about limiting their PPE. We heard some interesting stories from folks within broader healthcare systems that, surgery has been closed for 3 months anyway, so the surgical masks are being distributed to, the pediatric staff, the non-emergency staff, because they can't do surgeries right now. So sort of a reshuffling of resources there. Slow and difficult reimbursement, especially early in the pandemic when things were very unclear, was a huge issue. We were hearing from folks saying, I haven't gotten any reimbursements in the last 2 to 3 weeks, and so cash flow completely dries up. We saw a lot of providers who, are the owners of their centers, of their practices, stop taking salary for a period of time so that they had enough cash flow to continue paying staff, which is very similar to what we heard from the child care providers as well. I just sort of wanted to break out some of the trends here on this chart. Green is private insurance, blue is Medicaid, and then orange is sort of not, it says other because it's not really relevant what type of insurance we're talking about here. We were really interested to hear that you could see a lot of people had issues with telehealth billing, period, but actually they felt that private providers were handling this worse than Medicaid, because Medicaid had some guidance from the federal government about essentially, let's find a way to make this work urgently, but private insurance providers were slower to make those changes and sort of adapt. We heard more frustration towards that. You can also see here 20% of providers reported that they've had patients lose insurance, and that was from that big economic contraction and layoffs that we saw early in the pandemic. Small independent practices were the most likely to report a billing issue. This is probably similar to what we've heard from child care providers, that I just can't keep track of the financial at the same time that I'm doing everything else. And the only issue that was reported across all provider types was that loss of insurance. So showing, this is something that's facing all providers right now. Next slide. Before we go into some of the trends across them, I also just want to highlight this national research from the Green Center at I think it's Virginia Commonwealth University. They've been doing weekly or biweekly surveys of primary care physicians almost every week since the crisis began, and they have been kind enough to share with us their pediatric data broken out each week. And so we ran the numbers to get a sense of how do pediatricians, kind of compare to primary care physicians, and what are the biggest issues they're facing. So here, gray is the actual responses they gave in November, December, and they were also asked in that survey with the purple, reflect back to March or April, what would your answer have been? So you can see to some degree, I mean, this is retrospective, it's asking them to recall how they felt in the spring. But you can see that, folks would have said in March or April that their stress was at an all-time high. And then by November, even more of them felt that way. And so sort of, this stress level was only going to get worse. The suffering of their patients was only going to get worse over that time. Some of the financial issues did improve. You can see on sort of these middle three variables in here. The gray, the retirement one is different, but you can see that the gray bars are getting a little bit shorter here. And so that's progress, actually. We had a lot of folks in the early days of this study saying, my practice is going to close without additional support. Some of this is because, people came back to practices and it is a fee-for-service model. Some of this is because the federal government sort of invested some more resources where they needed to go. I am really taken by the fact that in March or April, 40% would have said they were ready and able to distribute a vaccine, but by November, just over 10% were saying that, which I think really points to the mysterious nature of the vaccine rollout, not just in South Carolina, but everywhere, constantly changing dates and priorities, and just a complete real guess right now as to when children will even be eligible to receive pediatric vaccines for COVID. Next slide. And we'll go to the next one. So I wanted to highlight here, actually go back to the first one. I wanted to highlight here that some of the things that these folks are worried about, child care providers on the left, medical providers on the right, some of it's really different by the nature of what their businesses are. Child care providers were worried about supplies for their even daily operations, things like groceries and wipes. You're still hearing from people like, I can't get Clorox wipes anywhere. And for some folks, that was just part of their regular cleaning operation anyway. If you'll remember the early days, that stockpiling, formula flying off the shelves, diapers flying off the shelves, the minimum or the maximums on milk. One of our providers said that she almost got into a fight with somebody at Aldi because they told her she was taking too many strawberries when she was trying to have fruit in for the kids in her child care center. And so those concerns were very specific to the child care providers accessing sort of regular operational supplies. The enrollment uncertainty still continues to plague them into the fall. On the other hand, with the medical providers, insurance reimbursement was just such a huge concern that we heard. Reimbursement is slow. I don't know how my telehealth stuff is being processed. I don't know how long they're going to do telehealth for. Following federal guidance, a lot of insurers sort of gave some flexibility about what telehealth software was being used. And so providers were able to use lower cost software instead of the more rigorous HIPAA compliant software. Well, how long is that grace period going to last? At what point are we going to need to make this investment in that technology? So a lot of uncertainty about what telehealth will look like in their business moving forward, though most did say that if insurance continues covering telehealth when we're back to normal, whatever normal is, they would like to keep using it to some degree, which was an interesting finding. We also heard from medical providers that they were concerned about the politicization of public health, that a conversation about wearing a mask might escalate or be rejected. Pediatricians are no strangers to talking about topics that parents might not want to talk about or might find controversial, but suddenly it was a new topic that they had to contend with. Next slide. So what really struck us was the similarities more than the differences. Supplies continues to be an issue. In particular, what we're hearing now is that access is a bigger issue than the cost. So the costs are now reasonable for masks and gloves when providers do find them, but that they're still having a hard time finding a reliable source of those. Especially with smaller businesses, smaller child care providers, and smaller pediatric practices, there might not be the upfront cash to buy the mega pack, at Costco of the gloves, because that might come out of their pocket. So even though that's more cost effective over time, it's not an investment they're able to make on their own right now. We think this is a real opportunity for sort of some informal partnerships for collaborative buying. The Palmetto Shared Services Alliance, for example, is sort of an umbrella organization that can help the child care providers with getting some discounts on supplies. This is even pre-pandemic, that by sort of pooling resources, providers are able to make their money go farther. So we think there's some real opportunities there. From both, we heard a feeling of being overlooked by government relief and financial assistance. There's been some progress for both since these surveys were taken, but not nearly the dollar amounts that are needed to help plug some of the gaps that are there. Cash flow, fear of losing their business and closing permanently, staffing concerns around payroll, unemployment, health and safety, and morale, stress and uncertainty, and this overarching question of how are the kids doing? Next slide. We asked providers to rank on a scale of 1 to 10 how they were feeling about their stress level in terms of financial stability of their business, the safety of themselves and others on staff, and the health and well-being of patients and families that they work with. The pediatricians are purple here, the child care providers are gray, as of the fall child care survey. You can see that health and well-being of the patients was the highest concern. So as much as we asked them to tell us about their practice and their operations and their struggles, at the end of the day, both were coming back to, I am worried about the families I'm seeing. I know how hard they have it. We also broke these out by the respondent type and found that the concerns really differed a lot by that. And so the financial concerns for child care providers were much higher among smaller or sort of decentralized locations, child care centers, home-based centers, and faith-based centers versus 4K and child care centers, which because of their involvement in state and or federal funding sources had a little bit more funding reliability. Child care homes were the most concerned about the safety of staff. This makes sense because to some degree staff is them in their house. These are people who are bringing children into their house right now, and that means that there's no clocking out from whatever gets introduced into the house through possible transmission. So it's not really a surprise that that would have a safety concern there. For pediatricians, small practices were particularly concerned about the financial health of their practice. And FQHCs, which are federally qualified health centers, generally you might call that like a public health center, they had the highest stress levels regarding both their staff safety and the well-being of patients that they serve. These are centers that often serve overwhelmingly low-income populations, and so they were very concerned about what their patients were facing at home and what their providers were facing in the office. Okay, next slide. Just to briefly say that our goal with doing this research is not to just put it on a shelf and not just to share it with you all. What are we doing with this research? We're collaborating with a lot of people, others in the state government, federal government, and other nonprofit organizations working in the state. I do think it is just really important, though, to collect and amplify these voices, especially for child care providers. We had many respondents say, thanks for asking. Thank you for taking the time to ask us about what we're facing. It felt very overlooked in early conversations. You know, they didn't shut down when the schools did. And a lot of them feeling like we need more to sort of get through this time. We're going to keep revisiting this research with more follow-up studies because we recognize that the crisis, it keeps changing. With schools, largely operating to some degree in South Carolina, the situation looks different on childcare and health. We've been working to sort of develop some resources, supports, and materials through other organizations, working with the AAP and some health foundations to talk about what supports providers need, and within the childcare world, working with first steps at both the state and county levels to share these findings so that they can understand more of what their providers are dealing with. And it's really fuel for advocacy. We're part of several federal advocacy coalitions that have really been taking these findings from all of the state child care surveys and saying, like, this is what we need to explain to legislators. These are not numbers on a page. These are people, and these are livelihoods, and these are communities. And so really just trying to help put some tangible figures to the just intangible but so important work that pediatricians and child care providers do. My last slide is just a link to the resources so that you can find these reports if you're interested. There's been 3 of them now. Please feel free to reach out to me with any questions about those if you get deeper into them and want to talk more. We're also really interested in hearing what didn't we ask about. You know, when you take a look at these surveys, what challenges are you hearing in the field that maybe need to be dug into and sort of incorporated into a next round to really understand what the field is facing. I think we have about 5 minutes left. I don't know if any questions came into the chat.
We don't have any questions that have popped up in the chat, but this is a great opportunity for everybody who has had an opportunity to take in all this great information Megan shared in her slide. If you want to go ahead and send us a question, we've got about 5 minutes.
Great. I'll note while people are, I'm sure, eagerly typing at their keyboards, if you are somebody who works closely with providers, I do encourage you to look at the actual reports, and I'm not just saying that because I wrote them. We made it a real priority to include a lot of qualitative feedback, and that was so important. I can talk about numbers and dollars and percents, but the stories are really in the frontline experiences of providers. In the spring survey of childcare providers, we had one provider say, well, I had to close for 2 weeks because my husband died of the coronavirus and I just couldn't work under those conditions. And in the fall version, we had one provider say, 4 of my staff have contracted this, 1 of them died. There are not percentages that I can show you to convey the human impact of this on those providers. When you read through their findings, actually, I mean, it's tough to talk about. I had to take time, off after working on these data to sort of walk away because the struggle is so apparent. Many of these providers in both sectors said, I've worked to build this business for 10, 15, 20 years, and I might lose it all right now. The commitment to children and families and their care is so paramount, I think, for many of them at the expense of their own well-being. So we definitely look forward to more productive conversations, moving towards recovery and rebuilding and building resiliency in this sector so that, God forbid, should there ever be another crisis in the future, providers are not left out there without a net.
All right. It looks like we don't have any questions coming through, so we might give you all the opportunity to take a little break and step away from your computer before the next session. Thank you all for joining us today. Thank you so much to Megan. Here's just a reminder, if you are looking for SC Endeavors credit, I have added the link into the chat box. Please click on that. You will be receiving this information, this slideshow at the close of the conference, and next week we will also be sending out recordings of the session. So with that, that's the end of our session. Thank you so much for joining us today, and thank you for the work you do. Have a great day.
Thank you.